Hi, so my name is Graham Skalley. I'm one of the anaesthetic registrars here at St Mary's, and I've come to present a case of COVID-19 in a third trimester pregnant lady who also had starvation ketoacidosis. So I'll first talk about the case, and then I'll talk about some of the learning points around both COVID-19 and ketoacidosis and pregnancy as well. So firstly, I saw this patient in September. She was 36-year-old. She already had 2 children. She was 34 weeks, and she was admitted to Alex-Bourne 1 on the 16th of September. She'd had a 3-day history of an unproductive cough, generally feeling unwell, a bit feverish as well. In terms of the fetus, everything was normal. Movements were normal. She had no bleeding, and everything was fine on the CTGs. She happened to be unvaccinated, and she lived in an unvaccinated household, and all of her contacts so happened to also be unvaccinated. She was, of course, tested when she came in, but her initial COVID tests were negative and PCRs were indeterminate. Obviously, we had a high index of suspicion. As you can see, her initial chest x-ray there is suspicious of COVID, but we'd had negative COVID tests. So the obstetrics team initially treated her with antibiotics, and later these were rationalized to some more respiratory antibiotics with clifomycin added. In terms of how she was when she came in, so her sats were 91% on room air. She had a high respiratory rate, heart rate was high, blood pressure was okay. She was started on oxygen. She also incidentally had 4+ ketones in her urine. You can see on the right from this initial blood gas, so her base excess is quite negative. This was something which wasn't initially noticed, again, focusing predominantly on her worsening respiratory condition. So by the next day, from the 17th on through to the 18th, her respiratory function worsens and the acidosis worsens. The midwife incidentally reports that she hadn't been eating much food in the last 5 days, just a scanty diet with a few snacks, but nothing proper. Anyway, in the interim, respiratory function worsens again, so CPAP is started. A positive COVID test now has been got, and she's admitted to ITU. So this is her X-ray after 2 days, I believe. So she's on ITU now with COVID-19 complicated by euglycemic starvation ketoacidosis. So this has now been diagnosed. She's not tolerating the CPAP well, so it was decided that we'll proceed with an emergency cesarean section the next day, a case that I'd done with a consultant. As you can see from her gas the day before we decided to do the section, she's become quite acidotic now, and the base excess is still very negative. She was treated with IV glucose, which I will talk more about the management of starvation ketoacidosis, but that is the mainstay treatment really to reverse this acidosis. So this is her anaesthetic chart during the case. The only reason I'm putting it in here just to highlight how unwell she was with the COVID. So if you can see my cursor on the mouse, you can see she's on really high oxygen, close to 100%, and her sats are still in the low 90s. So she was very unwell, and it wasn't a straightforward case, and she was relatively unstable. However, after delivery of the baby at 34 weeks, she was switched to 40% oxygen, so she'd made a drastic improvement. So in terms of the acidosis that we'd seen, so looking at the differential diagnosis, so she had a high anion gap metabolic acidosis, and this can be due to a number of things. A production of acids such as lactate or ketone bodies, and ketone bodies obviously being the case here. Could also be renal failure, but this wasn't the case in this patient, and paracetamol or other drug intoxication, which there was no evidence of this with this patient. She hadn't been taking any analgesics really. So the absence of hyperglycemia, so she was not diabetic, didn't have gestational diabetes, her sugars were normal. This, I guess, raises a diagnostic challenge in light of the metabolic acidosis. And she had 4+ ketones in her urine as well, so high levels of ketone bodies in the urinary analysis indicates that this is a ketoacidosis, and this is seen in non-diabetic starvation, which is a triad of increased anion gap acidosis, ketosis, and normoglycemia, each of which was present in this case. In terms of her management, so the mainstay management to reverse this acidosis, because it's usually refractory to other medical treatment, is removing the causative agent, which is the ketone bodies and the gluconeogenesis. And this is achieved with just IV dextrose. And as you can see from this chart of her blood gases on ITU, so on the 19th, this is when glucose was started. And pretty rapidly, it's actually reduced the acidosis. And she's, she fluctuated, she was probably deeper here, but on the whole, it's reversed it really quickly. And this has also been seen in the literature in terms of reversing the acidosis quite quickly. In terms of ketoacidosis and starvation, so this is actually very rare. There's only actually 3 cases in the literature of starvation ketoacidosis in pregnant women with COVID. And generally it's seen in the cases of diabetes where the insulin deficiency prevents the cellular uptake of glucose for energy. And then because of this, counter-regulatory hormones combined with the low insulin levels release free fatty acids, which are oxidized to make ketone bodies. And these metabolic changes occur in starvation. There's a reduced glucose intake, depleting the glycogen stores, and ketone bodies are made as an alternative energy source, which cause the acidosis. However, in healthy adults, it can take up to 14 days. However, in pregnant women, it's been seen in 12 hours, i.e. overnight, and they can get a pH of 7.3. So it happens really quickly. And looking at why this occurs in pregnancy, so there's 2 things that are happening in pregnancy, one that's predisposing pregnant women to starvation, and one that's predisposing them to metabolic acidosis. So looking at starvation, so pregnancy is a hypermetabolic state with accelerated starvation because the fetal placental unit consume large amounts of maternal glucose. And as I said, in the period of fasting as short as 12 hours, you can start to see ketone levels 2 to 4 times higher than non-pregnant women in the same state of minimal fasting. Additionally, pregnancy is a diabetogenic state. There is increased insulin resistance, enhanced lipolysis, elevated free fatty acids, all of these increasing the production of ketone bodies. On top of this, in terms of pregnancy itself predisposing to a metabolic acidosis in addition to the ketone bodies, the respiratory rate and minute ventilation increase in pregnancy, and this respiratory alkalosis is compensated for by renal excretion of bicarbonate. This, of course, reduces the buffering capacity of acids, which predisposes pregnant women to metabolic acidosis. And in this case, and with other cases in the literature of starvation ketoacidosis in pregnancy, there's always a concomitant infection. And this ongoing infection is likely to have added further metabolic demand, increasing the likelihood of starvation and then ketoacidosis. So there's been a few reports in the literature now of a link between COVID-19 and ketoacidosis itself. And this is actually predominantly in non-diabetic patients. So there's a few reports out and 65% are actually not diabetic. And there's some evidence now that the COVID virus itself binds to angiotensin converting enzyme 2 in the lung and pancreas, which serves as a cellular entry point, which causes direct pancreatic islet cell injury. There's also, in addition, downregulation of the ACE2, which leads to unopposed angiotensin 2 and reduced insulin production. So both of these are making the likelihood of ketoacidosis increased, and also further exacerbates the glycemic dysregulation, as the ACE2 also is involved in the regulation of the sodium-dependent glucose transporter in the intestines, so you don't absorb as much glucose. So this is just I guess a pictorial kind of representation of what happens with COVID and how it affects the angiotensin converting enzyme. So I put a handy arrow there where the ACE2 is. And this is, I guess, seen in quite a few cases now, but like I said, this is only the 3rd case, at least in the literature, that has a pregnant woman who suffers from starvation ketoacidosis and COVID. So in regards to the key points from this case, so across the literature with starvation ketoacidosis in pregnancy, it's something which is regularly missed by the initial medical team that sees these patients. I myself actually was involved in a case back in 2018 at King's College where this was missed. We had a pregnant patient who had quite severe influenza, and she also had a metabolic acidosis, and she had a scanty diet of biscuits for about 6 days. And she had a very deep acidosis, which was refractory to treatment, and she needed an emergency cesarean section, I think at maybe 29 weeks or 30 weeks, so quite early. And again, a new consultant came on who was an expert in acid-base disorders, gave IV glucose and reversed the acidosis pretty quickly. So something which we doctors understand the physiology of, the pathophysiology of this, but it's very easy to miss because there's always something else going on, a severe respiratory infection or something else which almost clouds the diagnosis of this. And likewise, in this case, it was quite bad COVID-19. I think the important things to think about is that pregnancy should be considered a high-risk period for ketoacidosis, especially when other stress factors are involved, such as an infectious disease. And ketone testing should be performed systematically in unwell pregnant women during the 3rd trimester. And usually these together will hopefully highlight that this is actually a case of starvation ketoacidosis and can be treated relatively easily, usually without needing an emergency cesarean section. But obviously that depends on other factors, which the obstetric team will be able to help with that. And that is everything. Thank you very much.
Thank you for such an excellent talk and what an interesting case. Can I ask a couple of questions? Firstly, did you give dexamethasone to the patient?
We did not initially before she went to ITU, and I don't think she received it actually before the cesarean section.
I only asked because I assume it would increase the insulin resistance. Can I also ask a second question? Could you take us back to the blood gases when you had them in a series? And I note that as the base excess improves, the acidosis seems to get worse.
Yeah.
Because of the rising PCO2, and could you just comment on that just to explain it to someone who's not so good as you guys treating this?
Well, I guess I suppose there's probably what do you think, Prof? I think there's probably a lag in the treatment because she has worsened in terms of her pH, but it is corrected in a very short period of time. So if you look at the worst, where it's 7.12 at 1 o'clock, yeah, by 8 p.m. her pH is already normalized.
Yeah, I think there are a couple of effects here. So firstly, we've got a mixture of arterial and venous gases, and the PCO2 is enormously varying in this. So you've got at the lowest point, she's got a PCO2 of 3, which is a combination of a low baseline in pregnancy, where we'd expect to see a lower PCO2, and then at one point the venous PCO2 is high as 8.9. So I think there's clearly a mixed pattern here, and there's quite a lot of things changing quite rapidly. I suspect that's probably the dominant effect there. But the underlying metabolic cause is responding quite quickly to the glucose, and then we're seeing a combination of respiratory and renal compensation.
And someone else has asked, was she vaccinated?
No, she wasn't vaccinated, and her husband wasn't vaccinated, and every contact she'd had in the last 2 weeks were not vaccinated.
Well, were you giving her sodium chloride? Because I noticed that her chloride levels are quite high, and often the chloride and sodium chloride bags can contribute to acidosis.
No, so I had seen her actually maybe 12 hours after she'd come in, just at that point, a severe respiratory infection. I was already thinking of starvation ketoacidosis anyway, just because I'd had a background and seen this before, but she wasn't given any sodium chloride. I think she'd had a liter of plasmolite earlier, but she was still managing to drink some fluid to herself. So she wasn't given any sodium chloride now.
Thank you very much. Did you actually do a HbA1c? Because often you can have glucoses that are just a little bit high and we can miss them. Did you know if she had a slightly high HbA1c at all?
I don't think she did, no.
Because some of the glucoses do go, I see there's a 12.5 there, and that's obviously in the context of giving dextrose. But
She did
otherwise,
have
no,
her BMs taken while she was on the ward before she went to ITU, before IV glucose was initiated, and her BMs were normal.
Thank you. And Dr. Bahari's asked a really important question. Just if we were to experience this on the wards, what concentration of glucose did you give, and what would you recommend?
Yeah, so she was just treated with 10%. So it doesn't need to be a high dose at all. Yeah, and that's every case. Well, I haven't seen that many cases. I've seen 2, but that's what's been used, and it's worked.
Worth reminding everybody that in terms of ketoacidosis, obviously this is really a really fascinating case of starvation ketosis, but we do tend to see alcoholic ketoacidosis in addition to diabetic ketogenesis. And the only other one that we should all think about it is in terms of euglycemic ketoacidosis, when the glucose is normal but they have raised ketones and an acidosis state, is a diabetic patient who's on something like SGLT2 inhibitors, which is increasingly common and increasingly more prescribed. And what was really key here is that you picked up on the base excess and the anion gap early, and that undoubtedly made a huge difference to the patient's case, but often it can be missed. So well done on doing that.
I'll be honest, I mean, the only reason I guess I didn't miss it was because I'd missed it once before a few years back. So yeah, you learn the hard way, I guess.
Well, that's fantastically honest.
No, I was going to say that I thought was I think it reinforces the importance of pattern recognition, and that once you've seen it or even heard about it, then you'll look for it again. So I think that's why I was quite keen that we shared it with a wider audience, and why I think actually it would be an interesting case report. I think what we'll do is we'll work out who the right audience is and where the right place for that to go might be, and I think we'd be very interested in doing it jointly with our obstetric colleagues, because I think they're, ideally they're the target audience who would probably pick this up before we'd normally see it. So that's who we'll talk to next. Good to see TG nodding.
Yeah, learning experience for me as well. Thank you.
Yeah.
Thank you.
And I assume mother and baby are well now?
Yeah, they did well. So she, once the baby was delivered, she was extubated the day after the cesarean section, and she was switched on to 40% Venturi the day after that, so 2 days post cesarean section. So yeah, she did well, and baby was fine.
And oh, sorry, there is a hand raised. Sorry.
The silly question after all this: did she get herself vaccinated after all that?
No, I did actually discuss with her why she didn't get vaccinated. I guess I spent a fair bit of time with her, so I just wondered, just in case there was anything that she'd misunderstood or she'd got, she had been ill-informed about. But I think there was a lot of suspicion around how fast it was pushed out. A lot of people in her family unit community weren't interested in vaccines, and there was, I guess, a belief that this was sort of a government conspiracy to try and make money off vaccines. So I guess those kind of deep-rooted thoughts and conspiracies you can't really change.
So she will be a good vaccine advocate now, but anyway.
I hope so.
There's some really good questions coming up in the chat that I've missed. I apologize. And the first one was, is this likely to occur in women with hyperemesis gravidarum? So if they're vomiting lots, but do you have any comments? I assumed that the vomiting would stop towards the latter half of the pregnancy, but please do.
Yeah, so I guess obviously women that are vomiting profusely come alkalotic rather than acidotic. However, it can also add to the starvation element. So as had been seen in previous cases and in ours, just 12 hours of not actually complete fasting, just of a minimal diet, will push a woman to start making ketone bodies. So it can happen very quickly with any other stressor that's happening. So it has been seen in hyperemesis, yes.
And then somebody else has asked, I guess, a question that's about to cause controversy between medics and obstetricians, as in, where is the best patient to manage the patient, under obstetrics or medicine? I've made the assumption the patient was managed in a HTU setting, but please correct me.
Well, to be honest, actually, I think everything was done right. So she'd had a medical review early. So I had seen her and gave my input. And then I'd asked the obstetric reg to get a medical review because she wasn't necessarily at the time needing to deliver. So she didn't at the point anyway that we had seen her need to be on the labour ward, apart from the fact that she was pregnant.
That's
So
brilliant.
yeah, so these women can be managed on a medical ward if the medical team were happy. But as with every other case, it escalates fast because the acidosis isn't treated early enough, and they end up having an emergency cesarean section anyway. And they usually inevitably end up on ITU because the acidosis is worsened so much. So I guess with early treatments, you could argue it could be done either the labour ward or the medical ward.
But it sounds like this is a case where there's a lot of collaboration, which is exactly what we want to see at Imperial, and Better Together is really reflected well in this case. I should make the point though that Charing Cross obviously doesn't have obstetricians on site, and during the waves of COVID, we were moving patients to St Mary's for that very reason. I think it's worked really, really well, withstanding the bed pressures that we're all under. So, and clearly this patient's had excellent care. And someone else has asked another excellent question that I wouldn't have considered. Was the baby tested for COVID?
No, I don't think they routinely test newborn babies for COVID. There's been some change in actually, because I've worked on a labour unit since the beginning of COVID actually, and originally when babies were born to COVID positive mothers, they used to be taken out of the room. I worked in the northeast of England. Here they're still kept in, and there's not, I believe I've been told there's not a worry that they will contract COVID directly from the mum being in the same room. So they're not routinely tested though. But I'm unsure what their risk is, to be honest with you. I don't think there's been much in there.
There's very little transmission to the fetus. It doesn't cross the placenta. And just to re-emphasize, it's just at Imperial, the good MDT collaboration is just amazing across all 3 sites and everything. So I think she came to the right place.